dysfunction due to an infectious agent. You can say that that patient is in sepsis. So regarding the definition of septic shock, it is actually a subset of sepsis in which the underlying circulatory and cellular metabolic abnormalities are profound enough to substantially increase the mortality. So when we come to the primary care, the most important aspect is that it is our responsibility to ensure that we are able to pick up infections which are actually leading on to multi-organ infections. That is, infections which can lead on to sepsis at the earliest, because it is at the primary care level that most of the patients might initially present. And the most important thing is that if you are able to diagnose sepsis at the earliest, so we'll be able to initiate the right treatment at the earliest. We'll be able to refer the patients to the secondary or tertiary care centers at the earliest, so that we can optimize the outcomes at the earliest. For example, all of us know that we are going through an epidemic season where we are having problems with leptospirosis, dengue is peaking, chikungunya is peaking, scrub typhus is coming up. All these things are problems. Now, all these infections can also lead to sepsis. For example, a patient with dengue developing multi-organ dysfunction, that is also a viral sepsis. Okay, so leptospirosis, leading on to the multi-organ dysfunction, that is actually the bacterial sepsis. All these patients will come to the primary care at the earliest. If you're able to identify the red flag signs and institute the right treatment before referral, probably will be successful in optimizing the outcomes for these patients. So with regard to this, WHO has taken sepsis as a serious challenge to the healthcare across the globe, and they have come out with a strategy so that the sepsis-related deaths can be reduced by 2030. And this is the magnitude of sepsis. Every year around 5 crore cases of sepsis occurs across the globe. And this contributes to around, say, 1.3 crore deaths. And 1 in every 5 deaths worldwide is associated with sepsis. So this sepsis could be either bacterial sepsis or viral sepsis, like due to dengue, etc. And 85% of these sepsis deaths occur in low and middle income countries. And 40% of sepsis cases occur in children less than 5 years of age. So why this topic is important to us, whenever we talk about infection-related deaths, like, we conduct this death audits at the district level as well as the state levels. And leptospirosis is actually a leading cause of death in the state, according for around, say, 250 confirmed leptospirosis deaths and around 150 probable lepto deaths. Around 400 leptospirosis deaths are captured by the state itself. Also, we have deaths due to dengue, deaths due to scrub typhus, etc. So whenever we talk about infection-related mortality, so our aim is to see whether we could have saved that patient. So we look at two aspects. So was there a delay to the diagnosis, or was there a delay to the initiation of treatment? For example, in patients who have risk factors like extremes of age or immunocompromised, or patients who are having on dialysis, patients with past history of CAD, etc., even influenza or COVID can actually lead to their mortality. And with regard to influenza, we know that the outcomes are going to be optimal if oseltamivir is started within 48 hours. So, within these 48 hours, who will have this opportunity to start oseltamivir for these patients? This actually the primary care doctor. So this aspect is very, very important. So whenever we think about bringing down the mortality due to any infection or bring down the mortality due to sepsis, so our aim must be to delay the diagnosis, and our aim must be to delay the initiation of the right treatment. So when we talk about sepsis, there are two things which are actually applicable to the primary care physicians, or to the physician to which primary care doctor to which the patient initially presents with features of sepsis. One is the initiation of antimicrobials. Okay, for example, if patient is presenting with features suggestive of definite or probable sepsis or septic shock, ideally the right antimicrobial has to be started within 1 hour of recognition of sepsis or septic shock. So this is absolute for septic shock. And if the patient is presenting with septic shock, the right antibiotic has to be started within 1 hour of diagnosis of septic shock. So the thing is that, suppose, the patient is presenting to you with, you are diagnosing the patient as septic shock, and obviously your responsibility is to refer to a tertiary care center. But suppose you are able to give an right antimicrobial within, say, 1 hour. So that is something which can actually bring down the mortality. So you can give the right antibiotic and then refer the patient. So that is very, very important. And regarding this, there is one other aspect, like if you are able to draw a blood culture, prior to initiating the right antibiotic, that has to be done. But in primary care setup, etc., drawing the blood culture is not really possible. So in the primary care, if you're suspecting a sepsis, severe sepsis or septic shock, then you have to give the antibiotic at the earliest and then refer the patient. So that is, this 1 hour window is important. Second aspect is actually the initial resuscitation. Suppose, patient is presenting to you with a hypotension and you are suspecting a septic shock, like for example, a patient uncontrolled diabetics and a patient is having a bad diabetic foot infection, and when you are examining the patient is with tachypneic and the BP is towards the lower side, you are making a diagnosis of a septic shock, and definitely you will have to refer the patient. But suppose you are starting the patient on an antibiotics like say Biprazole, Tazobactam or something like that. You give the first dose, you start the patient on fluids, and then if you are referring, then it will actually lead on to bringing down the mortality due to sepsis in that case. Regarding the initial resuscitation with fluids, the recommendation is that in any patient with septic shock, within 3 hours, we can, based on the cardiac status, etc., we can give crystalloids, that is either ringer lactate or normal saline, 30 ml per kg. So no need to give this 30 ml per kg, etc., in a primary care setting. You start the patient on fluids, and then that is either ringer lactate and NS, and then refer the patient. Now, coming to the approach to fever, that is, a patient is not going to come to a primary care, that is, CHC level or any clinic with a diagnosis of, say, dengue or, say, leptospirosis, from history alone, you may not be able to differentiate between a bacterial sepsis and a viral sepsis, etc. So basically, we need to have an idea regarding how we are going to approach fever in the primary care settings. So based on the duration of fever, suppose the duration of fever is less than 7 days, so we'll term it as acute febrile illness. So the duration between 7 and 14 days, we'll term it as acute undifferentiated febrile illness. So the duration is say more than 3 weeks, so we'll term it as pyrexia of unknown origin. So today we will actually discuss about acute febrile illness, because it is actually the acute febrile illness that can present you with features of multi-organ dysfunction initially. So acute febrile illness, the etiology could be infective, inflammatory, or neoplastic. But for all the practical purposes, for acute febrile illness presenting to you and the patient is looking sick, we need to consider it as an infective etiology. If it is an infective etiology, the next question that has to go through your mind is whether it is this sepsis is due to a bacterial pathogen, viral pathogen, or a protozoal pathogen. So protozoal pathogen becomes important if we are a malaria endemic region. Now, this is basically how we are going to approach this acute febrile illness. Basically, a patient who is presenting with fever and the duration is less than 7 days. So, a patient coming to you with a fever of 1 day or say fever of 6 days, both will fall under the category of acute febrile illness. So, your aim is to, if you want to start the right antimicrobial agent, definitely you should have a working diagnosis in your mind. So, this algorithm will help you to have a working diagnosis in your mind. A patient is presenting with acute febrile illness, and suppose he is having features of upper respiratory tract infection, like say a rhinitis and sore throat, definitely you will term the patient as having influenza-like illness. Influenza-like illness means the DDs will be like it is going influenza A, B, or the COVID like that. Second is, so whether you will be able to localize the infection to a particular organ system. So this is known as an organ-specific syndrome. Suppose the patient, like I talked about a diabetic foot infection, like patient is presenting with fever, you are examining the patient is having diabetes, and there is a very, very bad diabetic foot infection. We'll term it as a skin and soft tissue infection. Okay. Suppose a patient is coming to you with fever, and on history, the patient gives history of dysuria and flank pain, etc. You will say it is a genitourinary syndrome, cystitis, pyelonephritis, like that. Likewise, based on the symptoms, you can classify into a pulmonary syndrome, that is a patient presenting with fever, a pleuritic type of chest pain with, say, rusty sputum, etc. You can say it is likely to be a community-acquired pneumonia, that is a pulmonary syndrome. A patient is presenting with fever, headache, altered sensorium, seizure, etc. You can say it is a meningoencephalitis or an encephalitic syndrome, or you can say it is a CNS syndrome. Now we are having an outbreak of Shigella going on in multiple pockets in the state. A patient presenting with fever and a dysentery sort of presentation, and patient is in shock, you can say it is a gastrointestinal syndrome. Then a bone and joint syndrome, endocarditis, etc. So basically, suppose from the history itself, we are able to localize to a particular organ system, then you can say that the patient is having an organ-specific syndrome. And then based on the probable, for example, if it is cystitis, you have to cover E. coli, etc. Then algorithm is going to be different. But in our practice, the most perplexing presentation is going to be like patient is having a fever, patient is having headache, patient is having a myalgia, patient is having arthralgia, patient is having fatigability. You are not able to localize to a particular organ system. So here, this we will term it as a tropical fever syndrome. So our leptospirosis, our strep typhus infection, our dengue, chikungunya, Zika, all these things will actually come into this category. That is an undifferentiated fever or a tropical fever syndrome, where based on the history alone, you may not be able to differentiate whether the patient is what the diagnosis is going to be. So basically, a practical approach will be like any patient who is presenting to you with acute febrile illness. So we need to see whether it is a community acute infection or a healthcare associated infection. Like initially, you are trying to see whether it's an organ-specific syndrome. Okay, suppose you are identifying it as an organ-specific syndrome, like a patient is having cystitis. Next is, you need to see whether it is a healthcare associated cystitis or a community acquired cystitis. How can you say it is healthcare associated? Suppose the patient had a history of catheterization, or patient had a history of a recent visit to hospital, etc., a recent surgery, a recent instrumentation, then it is likely to be a healthcare associated infection. So for all practical purposes, majority of the infections which are likely to come to you are going to be community acquired infections if they are organ specific syndromes, like that. So, I will start with the commonest presentation, like, of all the acute febrile illness in any season, majority of them are likely to be respiratory infections like ILI. ILI means that a patient with fever more than 38 degrees Celsius, presence of cough, and duration less than 10 days, you can say that the patient is having influenza-like illness. If the same patient is having, say, breathlessness, dyspnea, then we'll term it as a severe acute respiratory tract infection. So a patient who is coming to your OPD with features of ILI, so all these possibilities should go through your mind. It could be COVID-19, it could be influenza, it could be a respiratory syncytial virus, it could be adenovirus, any other virus, mycoplasma, etc. But the thing that you need to keep in mind is that suppose it happens to be influenza and the patient is sick. As you know, there is a classification A, B1, B2, and C. Suppose the patient is looking sick, patient is actually tachypneic, etc. You need to start that patient on oseltamivir at the earliest, because oseltamivir is going to have a mortality benefit if it is started within 48 hours. So a patient with ILI and patient is actually having organ dysfunction, then that is an example of a viral sepsis. So in all these cases, you need to start on oseltamivir at the earliest before referring the patient. So the influenza, so this is going to be the algorithm sort of thing, that it could be influenza A or influenza B. Influenza A could be H1N1 or H3N2. So whatever it is, the drug which is going to work is going to be oseltamivir. And for maximal or optimal efficacy, oseltamivir has to be started within 48 hours of symptom onset. So this is from the state guidelines. So we have a combined ABC guideline to address these issues of ILI, because a patient who is coming to a primary care doctor with features of ILI could be either COVID or influenza. So we were going through a COVID season as well, along with influenza. Influenza is peaking now. So basically, our guidelines say that we need to categorize the patients into A, B1, B2, and C. So A means that it's a mild symptoms, mild fever, mild cough, mild sore throat, etc. Here, there is no need for any antiviral drug. You just can give just the supportive treatment, that is paracetamol or cetirizine, like that. But you need to teach them about the red flag signs. So when you need to come back. So in 24 to 48 hours, if the patients are actually developing the red flag signs, they need to come back, because category A patient can progress to B1, B2, etc. So can progress to B1 or C. So basically, so any patient you are sending back, you are terming it as a category A ILI. Category A patient requires only paracetamol, cetirizine supportive treatment, but you need to teach them about the red flag signs, like the presence of development of dyspnea, the excessive fatigability, hemoptysis, etc. You need to come back. Suppose the same patient develops high-grade fever and severe sore throat, then the patient is a B1. Will go into the B1 category. In B1 category, we need to start oseltamivir at the earliest. B2 means the same person. So suppose it is a pregnant lady or a patient on dialysis, an elderly person, etc., having mild symptoms, there also we need to start oseltamivir at the earliest, because for COVID-19, we are not using antivirals now. So COVID-19, the treatment starts only when the patient is having dyspnea, this category C. So what does this category C means? Category C means the patient is having red flag signs, like patient is having chest pain, patient is having hemoptysis, patient is having hypotension, excessive fatigability, cyanosis, dyspnea, seizures, etc. Definitely the patient has to be admitted in a hospital. So your aim in the primary care should be to identify the patients are referred to the tertiary care or secondary care at the earliest if it is a category C patient. But then usually before the patient progress to C, the patient would have visited you when the patient had B1 symptoms or etc. And our job is to start oseltamivir at the earliest. So these are the red flag signs that we should be looking out for, not only for influenza or COVID, for any infection. So these red flag signs you should keep in your mind. It will be good if your patients are educated also regarding the red flag signs, so that if the patients are sent back, if they develop these red flag signs, they can seek hospitalization, seek medical care again. So alteration of sensorium, breathlessness, drowsiness, chest pain, hemoptysis, excessive fatigability, syncope, palpitation. So these are the red flag signs that we should be keeping in mind with regard to any infection. So all of you must be remembering this checklist. Like, when in COVID, we used to have this home care, patients are categorized into category A, and then they are actually sent to home care. So this checklist was used actually. And suppose, any of these aspects turned out to be positive, then the patients had to be hospitalized. Like if the patient is developing alteration of sensorium, if the fever is peaking, dyspnea, chest pain, drowsiness, hemoptysis, excessive fatigability, syncope, palpitation, and if you had this pulse oximeter, etc., the saturation is less than 94, and if the pulse rate is more than 100, etc., the patient should come back for medical care. Now coming to this, ILA is actually, if you are taking the history properly, ILA is the easy sort. Like the patient, you will be able to localize the patient is having fever, sore throat, cough, etc. But the problem is like, you are not able to localize. Like, just like we discussed already, patient is coming to you with fever, headache, myalgia, arthralgia, excessive fatigability. You don't have a localization. So this is, they will categorize as undifferentiated fevers or the tropical fever syndromes. And, in our setup, in such a presentation, we should think about dengue, we should think about leptospirosis, we should think about strep typhus, chikungunya, Zika, malaria in certain pockets, endemic fever rarely, brucellosis, mealy, etc. So we will focus on the first 6: dengue, leptospirosis, strep typhus, chikungunya, Zika, malaria. Here, actually, the most important thing is that for leptospirosis and strep typhus, we are able to start the doxycycline at the earliest, especially within 48 hours, probably will be able to, prevent the progression of the disease. We need to start this antibiotics at the earliest, for leptospirosis, strep typhus. Chikungunya is just supportive. Dengue, dengue actually can kill anyone. So there's something that we have learned. Dengue can kill actually any patient. So basically, we need to be aware of the red flag signs. So in dengue, we need to see whether it is a dengue with warning signs or the patient is progressing to severe dengue, like that. Okay. So in leptospirosis, strep typhus, we should be able to diagnose them at the earliest and start doxycycline. For dengue, we should be able to diagnose these red flag signs at the earliest and to identify capillary leakage at the earliest and then refer the patient. And now coming to the organ specific, I'm not going to spend much time on these organ specific syndromes. Like a patient, you are diagnosing the patients as having, say, a patient is coming with right hypochondrial pain, omitting, or right iliac fossa pain, omitting, and patient is having a fever, and patient is having tachycardia, and the urine output is coming down. So you know that patient is in sepsis. So if it is iliac fossa pain and there is tenderness and godding, it's actually probably an appendicitis or a perforated appendix, or if it is hypochondrial pain, like it could be a cholecystitis or cholangitis, like that. So in such a scenario, you are diagnosing it as a complicated intra-abdominal infection with sepsis. And you're going to refer the patient definitely, but you need to start them on some antibiotic at the earliest and then refer the patient with, the crystalloids. That is something which has to be done. For example, if it is, an appendicitis sort of thing, you are, that the implicated organism is likely to be gram-negative. Use antibiotics like, say, ceftriaxone, piperacillin, tazobactam, which will cover the gram-negatives. For example, suppose you're suspecting a pyelonephritis with sepsis also, there you need to cover E. coli, Pseudomonas, etc. Also, there also use piperacillin, tazobactam. Give the first dose of antibiotics, start the patient on crystalloids like say NS or RL and then refer the patient. So now, optimizing the pretest probability, like, how are you going to diagnose? For example, we discussed about, like we said that in influenza, you need to start oseltamivir at the earliest. If it is suspecting, you are suspecting leptospirosis scrub, you need to start doxy at the earliest. So how can you make such a diagnosis in the first visit itself? So, this you can have a working diagnosis in your mind based on the geographical location sort of thing. Like, for example, if you're in Trivandrum now and patient is coming from Matrigao area or from the collectorate area, etc. We know that there is an outbreak of chikungunya as well as dengue going on. Dengue, we have pockets across the state. Chikungunya, there are certain pockets. So based on from where the patient is coming and what is circulating in the community, we can make a diagnosis. The seasonal trends very important. Occupational exposure is also very, very important. Suppose a butcher is coming with fever, polyarthralgia, etc. You need to think about brucellosis as well. The travel history very important as far as malaria is concerned. Exposure to the pets, food and water exposure. We have huge outbreaks across the state with regard to Shigella as well as hepatitis A, etc. So, if you're having a detailed history, probably actually we can zero in on what is the probable diagnosis. The seasonality very important for us, the infections which peak in the rainy season, like the arboviral infections like dengue, chikungunya, etc. peaks. Scrub typhus peaks during this period. Leptospirosis peaks. Melioidosis, even though the cases of melioidosis in the state are not very, very high, but still a patient is presenting with multiple abscesses and diabetic, etc. We think about melioidosis as well. Malaria also, increases during the monsoon period. And, suppose you are in the Malappuram, Palkad, Wayanad, Calicut area, etc. We have been having multiple outbreaks of Nipah, especially during May to September. So any patient who is coming to you with encephalitis in this season, anywhere in Kerala, one of the DDs we need to ensure is, we need to consider is Nipah encephalitis. Another aspect is that, when you are working, IPC practices has to be spot on. So we should always be wearing the mask and practice the 5 moments of hand hygiene so that we can safeguard our health. And in Wayanad area, that is, you have this Casimir forest disease, which mimics dengue in the first week, and then towards the end of the second week, the patient will develop encephalitis. Casimir forest disease also, there is a seasonality. It is from December to May, where the nymphal activity is going to be maximum. And once the rain starts, the nymphal activity will come down. So the seasonality of KFT is December to May. So knowing the seasonality also will help us in, focusing on the proper differential diagnosis. Now, I will take you through some scenarios. So this is a 26-year-old pregnant lady, 14 weeks of gestation, present with fever, headache, maculopapular rash, arthralgia, non-purulent conjunctivitis, and limb edema. So dengue NS1. So this could be, say, dengue. It could be, say, chikungunya. Okay, it's an acute febrile illness with fever, headache, rash, conjunctivitis, and arthralgia. So the dengue NS1 and PCR were done. So if you want to diagnose dengue in the first week, it has to be NS1 or PCR. From the day 7 onwards, it will be dengue IgM ELISA. So that everyone knows. So the NS1 was negative, PCR was negative in the first week. Dengue IgM ELISA was positive in the second week. So what is the probable diagnosis? So the thing here is that, if the dengue NS1 was negative in the first week and PCR was also negative, and IgM is becoming positive in the second week, you need to think about, infections where there could be a flavivirus cross reactivity. So that is always possible in Kerala, where, all these viruses are circulating. So we have circulation of dengue to an extent, Japanese encephalitis and Zika and Trivandrum, etc. So, there is a cross reactivity between Zika as well as dengue. So if IgM ELISA is positive and is in the second week, and in the initial week, if NS1 as well as this thing was negative and patient had present with a fever with rash, you need to think about a Zika. So this was a case of Zika infection. So any pregnant lady presenting with fever and rash in our state, we need to rule out Zika as well, because Zika has implications as far as embryotoxicity is concerned. So some of the features of Zika will be like, it's not easy to differentiate between dengue, chikungunya, and Zika. So usually they said that Zika is actually a milder form of chikungunya. So like, patient will present with fever, arthralgia, etc., rash and all, but, the arthralgia won't be as severe as in chikungunya. We need to think about Zika. And this Zika is a cell-limiting disease, but in pregnancy, there are other implications. That is why, in pregnant ladies, we need to rule out Zika as well. So how to differentiate between dengue, chikungunya, and Zika based on symptoms alone in the clinic is not really easy. all of them will present as acute febrile illness. This myalgia and arthralgia is likely to be higher for chikungunya when compared to dengue or Zika. And Zika, it is going to be the least severe intensity. And edema of the extremities. In dengue, you can have edema when you are having a capillary leakage. It's not sick in the same presentation, but you're having edema of the extremities. You need to think about Zika. You can have rash in dengue, chikungunya, as well as Zika. You can have rash everywhere. This non-purulent conjunctivitis favors actually Zika over dengue and chikungunya. Retroorbital pain is sort of classical for dengue virus infection. And then investigation-wise, it's not really possible. If you're having severe thrombocytopenia or hemorrhagic manifestation, it is likely to be dengue. So, this is the telltale, the leptospirosis eye. Like a patient is having subconjunctival hemorrhage and patient is having a jaundice. We don't have any other DD in our state other than leptospirosis. But the problem is that in the primary care, the chance of a patient presenting with this classical lepto eye is unlikely. Like, it will be towards the day 4 or 5 you are going to develop the classical features of leptospirosis. So usually when the patient is presenting to the primary care, the patient will be having features of the fever, myalgia, headache, with or without diarrhea. And it may not be easy to differentiate between leptospirosis and dengue or scrub based on the symptoms alone. That is where the epidemiological link becomes very, very important as far as leptospirosis is concerned. So, and why this is very important for us is I will take you through this case and you will understand. So this is like a 23-year-old gentleman. He was a guest worker from Assam working here. He was referred to a medical college from a private hospital, and they had suspected mpox with MODS, monkeypox with multi-organ dysfunction. And then the presentation was, he had fever, myalgia, and headache of 4 days duration. He had epistaxis, ecchymotic lesions or the face and trunk of 1 day duration, had dyspnea, and he had features of on arrival, he was in hypotension, had features of ARDS, myocarditis, DIC, hepatorenal syndrome. So basically, the liver was involved as well as the kidney is involved. So this is the classical presentation of leptospirosis. And unfortunately, this patient died within 4.5 days. So this is a problem. Leptospirosis in our state, when we're doing the death audit, the death is occurring between 4.5 to 5 days. So you are not really getting a time to intervene. That is why, in the initial visit itself, we need to do something like start doxy, etc. If you are suspecting leptospirosis, because we may not be able to, we may not get a second opportunity to start the patient on doxy or some antibiotic. Okay, so this is how usually the leptospirosis deaths are occurring. Like patient is having fever and myalgia, arthralgia with or without diarrhea for say, and within say 4.5 days, the patient is developing multi-organ dysfunction, they are dying. The problem in this case was, these sort of lesions, which are not classically seen in leptospirosis, necrotic lesions were there. And this case was proven as leptospirosis using the PCR. That is another important thing, take-home message. Leptospirosis, if you want to diagnose in the first week, there is only one test which we can do. That is a leptospirosis PCR, which can be done in the public health lab as well as the regional public health lab in all districts. The leptospira IgM is going to be positive only from day 7 onwards. So these were the differential diagnoses we had entertained. So it could be a viral hemorrhagic fever, rickettsiosis other than scrub, meningococcemia, anthrax, Wheal syndrome, pox. It turned out to be a case of Wheal syndrome. Suppose this patient had presented to a primary care center in day 2, etc., with this fever, headache, myalgia, and all. Would we have started the patient on doxycycline upfront? So this is the big question. So the thing is that usually our fever guidelines say that we need not do any investigation till day 3 and we need to do something or start a definitive treatment only after day 3. So that fever guidelines is getting amended because, like we discussed about influenza. Influenza, if you want to maximize the effect or efficacy of oseltamivir, it has to be started within 48 hours. There is no point in waiting for 3 days and then starting later. And for influenza, we need to start oseltamivir only if the patient is presenting with B1, B2, or C symptoms. Likewise, in leptospirosis, also when the death is happening by 4.5 to 5 days, waiting till day 3 to do something does not make any sense for a disease which is leading to around 400 deaths every year in our state. 400 deaths are the ones which we have captured. There may be more deaths with leptospirosis. So how can we actually optimize the antimicrobial treatment in this case? So what we can really do with regard to leptospirosis is like there are four arms. So the prevention, primary prevention or chemoprophylaxis. So even though we say that doxy has to be started at the earliest, the maximal benefit of doxy in preventing the disease severity is when it is used as a chemoprophylaxis. That that we know the high risk groups, the NREG workers, the farmers. But over the last 4 years, we understood that almost all the manual laborers, will fall under the high risk group for leptospirosis. And unfortunately, I said that dengue it's more of an urban disease and anyone can die due to dengue. Whereas as far as leptospirosis is concerned, anyone can get leptospirosis, but unfortunately the mortality is occurring mainly in the BPL people who are always coming in contact with contaminated water, as part of their occupation. So all the those who are having this high risk occupation, they should be educated about the primary prevention, like using the gumboot, gloves, etc. Also taking doxy 100 milligram 2 tablets every week. Doxy might give protection up to 1 week. So that is our responsibility. Whenever we are coming across people who are likely to get exposed to contaminated water with rodent urine, etc., or any animal urine, so we should be educating them about the primary prevention possibilities. Second is, we should be able to identify, leptospirosis at the earliest so that we can start doxy at the earliest. Supportive therapy, immunomodulators, etc., for the tertiary care centers. So at the primary care level, how can we identify, any acute febrile illness? How can we identify whether it could be lepto? Because we need not worry about scrub, because if you are starting doxy, it will work for scrub typhus as well. So any patient with epidemiological link presenting with fever, headache, myalgia, with or without diarrhea, we should be immediately starting on doxycycline. So this is very important. So any person with fever, headache, myalgia, with or without diarrhea means, so almost all the infections that we discuss, like or influenza can present like this, sore throat is also there, or dengue can present like this, say chikungunya can present like this. So how will we differentiate between, say, whether this presentation is due to dengue or leptospirosis? That we need to look at the epidemiological link. That suppose the patient is having a high risk occupation, like a farmer, patient is having, say, cows at home, something like that. Patient is an NREG worker, patient is a manual laborer who is likely to come into contact with this water, etc. If this is this presentation, definitely that we start the patient on doxycycline. Another way is that, if you can do this is starting doxycycline on day one itself, at the first visit itself, start the patient on doxycycline. Another way is that you can do a total count, and if the total count is less than 4,000, it's likely to be like a dengue sort of presentation. More than that, probably it will be better to start on doxy. And then the next thing is that you should know when to refer these patients, as you need to look for red flag signs, and this is applicable to almost all the infections. So red flag signs means that the patient is actually moving on to organ dysfunction, means that the patient is progressing to sepsis. The presence of tachypnea, tachycardia disproportionate to fever. So usually if there is a 1 degree Celsius rise in temperature, you can expect a heart rate increase up to 10. And if it is, 1 degree, if this is a 1 degree Fahrenheit increase, you can expect a heart rate up to 10. There is a 1 degree Celsius increase in fever from the baseline, you can expect a heart rate increase up to 18. Okay, so I suppose the heart rate is increasing beyond this, you need to suspect myocarditis and refer. This is hypertension, present jaundice, alteration of sensorium, oliguria, hemorrhagic manifestations, any infection, it is better to refer the patient. Then regarding doxy prophylaxis, that is also our responsibility, because in the primary care, we are the ones who are having maximum exposure to. We are more like family health physicians, right? So basically, it's our responsibility to ensure that people who are having high risk occupation in our vicinity are coming to us. We need to educate them about the prophylaxis for leptospirosis, like doxy prophylaxis, as well as the encouraging them, especially farmers, to use these gumboots, gloves, etc. Now coming to our major problem, that is, in this season we are having a lot of cases of dengue in circulation. And dengue can lead to severe dengue as well as hemorrhagic manifestations, and patients can die. So any patient with fever and rash, with a headache, myalgia, etc., this season, think about dengue infection. And how to diagnose dengue? In the first week, it has to be dengue NS1 or PCR. In the second week, it has to be dengue IgM ELISA. So, in the first week, please don't do dengue IgM and say that patient is not having dengue. Now, why this is important? So, usually when we are looking at the dengue outbreak years, we know that the mortality is always higher in outbreak years. For example, 2017 was a huge outbreak year for dengue. And there, what really happens is that, just based on platelet count, when the referrals are being made, our tertiary care centers will become flooded with dengue patients. And dengue, the treatment is very, very complex because we need to identify capillary leakage at the earliest sort of thing. So that is the reason why, the primary care should be sensitized about, when to refer dengue. For example, you can see the dengue case fatality rate in our state is around 0.20 now. Aim WHO standard is that we should be able to bring it down to 0.05. In 2017, you can see it's a huge outbreak year where the CFR was actually much higher than this. So how can we bring down the case fatality rate due to the viral sepsis induced by dengue? We should be aware of this classification. There's dengue without warning signs, dengue with warning signs, and severe dengue. So our role in the primary care is to identify patients with features suggestive of dengue. That is, patient with fever, headache, retroorbital pain, myalgia, etc. So, the working diagnosis is going to be dengue. There, for dengue, the treatment is going to be just paracetamol initially, and then, asking them to take isotonic fluids like salted kanji water and all. So that is going to be the treatment that we initially give to dengue patients. Okay. And then we should actually educate them about the warning signs. So what are the warning signs of dengue? So one is the intense persistent abdominal pain or tenderness. Intense persistent abdominal pain means, so that is the marker of capillary leakage. So when this capillary leakage occurs, dengue, usually the febrile phase will last for say around 3 to 7 days. And then in certain patients, the patients will go in for capillary leakage during the critical phase. So there are 3 phases. One is the febrile phase, critical phase, and the third is the convalescent or the resorption phase. So certain patients will progress at the end of the febrile phase, will progress to the critical phase. So how will we identify that? These are the patients who should be referred. So that we can identify them using the red flag signs. So of this, the most sensitive marker is the patients presenting with intense persistent abdominal pain and tenderness. So if they are having intense persistent abdominal pain and tenderness, there is a 90% chance of capillary leakage and around 82% chance of shock. Persistent vomiting. So how do you define persistent vomiting? There is 3 episodes vomiting in an hour or 4 episodes in 6 hours means that the patient should be referred. Presence of fluid accumulation, like patient is having the pedal edema, ascites, etc. Definitely capillary leakage has started and should be referred. The mucosal bleeding, excessive restlessness means fatigability, lethargy, restlessness should be referred. Postural hypotension, that's very, very important. And early, the marker of a compensated shock in dengue will be a postural hypotension. Suppose the patient is saying that when I am getting up from sitting to standing position, I am feeling giddiness. Definitely, we need to look for postural hypertension. If postural hypertension is there, definitely a referral has to be made. Then the presence of liver enlargement and progressive increase in hematocrit. So these are the red flag signs. And any patient with, any viral fever patients or any patients coming to you during this season with red flag signs, definitely you need to refer the patient. And it means the red flag signs are there, means the capillary leakage is about to start, and you can refer and after putting in normal saline or ringer lactate, ideally ringer lactate. So that can be done. So this is something which you need to keep in mind because during this season, certain patients are present just with. I remember last year in one patient in Pathanamthitta presented just with intense persistent abdominal pain, and actually the patient was referred to the surgeon. Okay, so and then later it means only they realized that it is actually a dengue fever with warning signs, and by that time the patient had progressed to shock and patient died. So intense persistent abdominal pain in any patient with fever during this season, please think about a dengue with warning signs. And this is the state's referral protocol. Like any dengue fever without warning signs, you can treat. There is no need to admit. Just teach them about the red flag signs. Just teach them about the need to take isotonic fluids like ORS or a salted kanji water. So we don't advise them to take the hypertonic fluids like your usual water. So if warning signs are there from the primary care, the patient should be referred to the secondary care. And then it is like, along with warning signs, if there is evidence of capillary leakage, should be referred to tertiary care like that. So we will focus on the primary care, what we can do. Without warning signs, definitely you can treat. And those patients who are sent home, definitely teach them about the warning signs. And if warning signs are there, at the right time, you can make the referral. So basically, dengue without warning signs, primary care can treat. Dengue with warning signs should be referred to secondary care. And severe dengue patients should be identified from the secondary care and referred to the tertiary care. So if we are doing this properly, we can ensure that only patients with capillary leakage reach the tertiary care centers, and that is how we can optimize the logistics and resources in the tertiary care centers to bring down the mortality due to dengue-induced viral sepsis. So the next the infection we should be aware of is actually strep typhus infection. So like strep typhus, it will respond only to theoretically, even though we say that doxy is the should be given to all means if the patient is hospitalized for leptospirosis, we'll be using CP. But in the OP basis, we'll be using doxycycline. But other antibiotics also do have effect against leptospirosis. But as far as strep typhus is concerned, we don't have that much options. It has to be doxycycline or azithromycin, and to an extent rifamycin. So here is one case, a primary fever, myalgia, headache, dry cough, fatiguability, 10 days duration, no localizing symptoms or signs. Patient was treated with oseltamivir or augmentin, no improvement. Hence referred means to as all the tests were negative. And on close examination, you can see an eschar sort of thing. So eschar is there only in around say 25%. So only means in a busy practice, we may not be able to examine the patient for eschar, etc. Because usually it is there in the hidden parts like inguinal area, genitalia, below the breast, axillary area, etc. So if you can see an eschar, you can convincingly say that the patient is having a strep typhus infection. But otherwise also, if the patient is not responding to beta-lactam antibiotics, think about the possibility of strep typhus infection. This, just like leptospirosis, can result in multi-organ dysfunction syndrome. And there the treatment of choice is going to be doxy. So, and that is why we always say that in Kerala, if it is not an organ-specific syndrome, if it is a tropical fever syndrome, and you want to use an antibiotic, that has to be doxy. So, because it will cover leptospirosis as well as strep typhus infection. These are, the images of the eschar. So you can see the eschar on the scrotum like that. It looks like a cigarette burn, painless burn. Now, I will end the session with some diagnostic hints. Like a patient presenting with fever, conjunctival congestion, severe myalgia, jaundice, acute kidney injury, muscle tenderness, high-risk job leptospirosis. So leptospirosis, our focus has to be on the epidemiology. So the high-risk job or any chance of coming into contact with contaminated water, and if they are presenting with fever, headache, myalgia, and usually the calf muscle tenderness will be very, very profound, etc. Definitely start them on doxy. Fever, myalgia, conjunctival congestion, rash. Think about dengue. Usually rash is not there in leptospirosis. The obvious rash is not going to be there in leptospirosis. Like you are not going to see a dengue-like rash in leptospirosis. Features of dengue with second week encephalitis, KFD in Wayanad area. Then I will just take you through the things which are important. Fever, rash, toxic look, no response to usual antibiotic. But we always say that the usual antibiotic in Kerala has to be doxy. But many people use cephalosporin antibiotics initially. But that is not going to work against strep typhus. So that is why we say that you want to use an antibiotic in Kerala, it has to be doxy. Fever, chills and rigor, periodicity, splenomegaly with history of travel, etc. consider malaria. So every year we are having 1,000 cases of malaria. A lot of guest workers are here. So if there is a classical chills and periodicity, and even without travel, we need to think about malaria in our setting as well. And usually conjunctival congestion and lymphadenopathy are absent in malaria and enteric fever. Respiratory symptoms are usually absent in dengue, malaria, leptospirosis, and chikungunya, etc. Fever, non-purulent conjunctivitis, rash, and swelling of limbs, think about Zika. Especially in any pregnant lady with fever and rash, think about Zika in our setting. Contact with livestock, consumption of unpasteurized milk, and acute febrile illness with multi-organ dysfunction, think about brucellosis. Chikungunya presents as fever, arthritis, facial flush. There's known as the chick sign, there's a nose, etc. You will have the maculopapular rash. So it's a classical feature of chikungunya. Then fever with rash, in our setting, any patient with fever with rash and multi-organ dysfunction, or patient presenting as viral sepsis, fever with rash, think about measles, rubella, IMN, dengue, strep typhus, chikungunya, Zika. Of this, rubella, IMN, Zika, etc. are not going to present you with multi-organ dysfunction. Okay, measles can lead to pneumonia, etc. Then dengue, strep typhus, chikungunya, you need to be worried about. And if you are able to do the counts, if there is a leukopenia, the count is less than 4,000, the chance of it being a leptospirosis is less likely. It's more likely to be other viruses. So if there is a leukopenia plus thrombocytopenia in our setting, always think about the possibility of a dengue virus infection. Now, regarding sepsis preparedness, we know that as primary care physicians, it is our responsibility to ensure that all all the people in the vicinity, they are actually healthy. Like there's a role of family a cardiac failure, dialysis, etc. So all the commodities have to be kept in check. And also during the seasons where there is an outbreak of influenza, etc., we need to ensure that all our elderly population and those who are having commodities, etc., we should advise them to wear masks, especially in the 3C situation. 3Cs means a congested place or a crowded place, and when they come into contact with the person within 6 weeks. 6 weeks. And also the vaccination, especially in elderly and all, and those who are having comorbidities, annual influenza vaccination is definitely going to be of help to us. And 2030, the global agenda for sepsis actually gives importance to the primary care doctors. They also realize that if you want to bring down the mortality due to sepsis, we need to ensure that this sepsis is diagnosed at the earliest. There is everything depends on the clinical acumen of the primary care physicians. If they are able to diagnose the sepsis at the earliest and start them on the correct treatment the earliest before referral, we can bring down sepsis to a big extent. So the take-home message is whenever we're having an acute febrile illness, we need to have a syndromic approach. We need to see whether it is an ILI-like presentation or an organ-specific syndrome, or is an undifferentiated fever as a tropical fever syndrome. Which is a tropical fever syndrome, can it be dengue or can it be leptospirosis? And leptospirosis, we need to start doxy at the earliest. So can we ensure that we give doxy to the right person? So any patient with fever, headache, myalgia, with or without diarrhea, and if there is an epidemiological link, that is epidemiological link, you can take it as a high-risk job. Like farmers, NREGA workers, manual laborers who are likely to come in with contact with contaminated water, start them at the earliest on doxycycline. Risk stratification, very, very important. The best example is going to be the ILI guidelines, where, even if the symptoms are mild and the patient is having comorbidities like, say, patient on dialysis, patient on cirrhosis, patient with, say, cardiac failure, etc., despite mild symptoms, you're supposed to start on Vasseltamivir. Any patient, you are sending back, ensure that you are teaching them about the red flag signs and when they should come back. Also, if a patient is presenting to you, ensure that you actually screen them for all the red flag signs, and if red flag signs are there, definitely refer at the right time, and also optimal antimicrobial therapy. So thank you very much for the opportunity.
Thanks a lot, Dr. Aravind. Actually, it was, it was an eye-opening session in the literal sense, and you actually shared the, one of the very complicated facts into a very, palatable form, in a very nice palatable format, and there is no words to thank you from the bottom of the heart on that aspect. Now, before going through the questions, there was a small voice breakage in between, especially when you discussed about optimizing BMI in the preparedness part. Can you just share a few words on that?
Definitely. Actually, during our response to COVID, we understood that, when we are actually struck with pandemics or like epidemic, like dengue, etc., the maximum morbidity and mortality is for people who are having uncontrolled comorbidities, like, uncontrolled diabetes, uncontrolled hypertension, etc. Another thing was those who are obese, really obese, when the BMI is actually more. Means, for example, with this COVID, them developing severe COVID is higher, chance is higher. And suppose it is influenza, also the chance of them developing influenza, pneumonia, and ARDS is higher. So it's our responsibility to ensure that, our future is a really healthy. It's like that is why we started the Shiley app to screen everyone for diabetes as well as hypertension, and also screen for obesity. And if there is if they're obese, we need to ensure that through proper lifestyle interventions, we need to bring down the BMI. We need to ensure that diabetes and hypertension is diagnosed at the earliest. And if diagnosed, we need to ensure that these commodities are is under control. So who can do this? Actually, the primary care physicians are the ones who are best equipped to do this, because they are the ones actually who are at the first line of contact with the public, right? So tertiary care doctors, etc., they are the ones who treat all these complications. If primary care is really strong, we can prevent these sort of complications from occurring.
That's thank you, Dr. Aravind. Thank you very much for that. And there are, there is some queries regarding focus on 3Cs and ventilation.
So the 3C approach means that ideally means after COVID, whenever we talk about mask and all, use of mask, and a lot of people who look at us in a very, very skeptical fashion. So ideally, all people who are having these comorbidities, elderly, the extremes of age, and those who are having dialysis, CKD, etc., they should be using mask whenever an outbreak, so influenza, COVID, etc., are going on. For example, during this season, so influenza is speaking, we had the peak of COVID, and now it's coming down, and like that. So in which all situation should we use the mask? That is where the 3C will come into the picture. So 3C means the closed space. For example, in a hospital-like scenario, a closed space maybe when you are in the lift or elevator, it's a closed space. So the same thing might apply to the elderly population as well. So for example, if they're coming to the hospital and they are using a lift and all without mask, and there is always the chance of them picking up an infection. A congested space is like a market. So whenever this patients with comorbidities and the elderly, etc., are going to markets, ensure that they are wearing masks. Then close contact is the third C. Close contact means, if you are coming into within, say, 6 feet of another person, the chance of you picking up a droplet infection is higher. Suppose the other patient is having a respiratory infection. Asymptomatic transmission is also there for influenza. And we know that we are very healthy people, and suppose we are getting influenza or COVID, it may not be a major problem. But suppose a 75-year-old is getting this infection, it may be detrimental for them. So we need to ensure that the elderly, as well as those who are having comorbidities, even for the apparently healthy who had severe COVID, etc., in the past, then we know that we are also likely to get this infection. The 3C settings, we need to ensure that masking is mandatory, especially during the outbreak seasons. The ventilation actually applies to the schools and all. Usually the infections are brought home by the children. So that is, the elderly at home are getting infected by, by their grandchildren. So if you want to bring down the infections in the children, we need to ensure that air quality in the schools, etc. A lot of countries have invested a lot on ventilation in schools, and in Kerala also a lot of companies are discussing that option. That is, ensuring air quality in schools. So that is the ventilation aspect. That applies to hospitals as well. I think IMA did a wonderful job during the COVID, ensuring that our OPDs are having good ventilation, like that.
Thank you. Thank you, Dr. Aravind. And now, is a test dose necessary before antibiotic in sepsis?
That's a very, very tricky question. So this will be answered when the National Antimicrobial Stewardship Guidelines will be released this year. Actually, the test dose is required only for penicillin group and those with past history of anaphylaxis to penicillin. But we know about things happening, right? Even in a case of where Pandoc was administered, people made a lot of fuss saying that a test dose was not given. Scientifically speaking, any history of anaphylaxis to penicillin or penicillin group, definitely we need to go for a test dose. Otherwise, not needed for other antibiotics. Then, but why I said that when the National Antimicrobial Stewardship Guidelines get released, this will be sorted out. Then we can really show that the national guidelines clearly mention that test dose is not required. It's required only for penicillin and in patients who had past history of anaphylaxis to penicillin.
Really? And should we give the first dose antibiotic as bolus or infusion?
The thing is that our aim must be to start the antibiotic and then refer the patient, right? So basically, suppose you're suspecting septic shock, it's going to be like you are starting the antibiotic, and then with the antibiotic on flow, we are going to refer the patient. So ideally, there are antibiotics which can be given as bolus. There are antibiotics which cannot be given as bolus. So it will be better that if you start it as an infusion and refer the patient, our aim must be to ensure that the patient reaches the next hospital the earliest.
There are few questions regarding oseltamivir as well as the doxycycline. Let's start with the doxycycline. This doxycycline, how far it is safe in pregnancy and also in small children, and also about doxycycline dose in pediatric when we have 100 milligram capsule available.
Regarding the doxy safety in pregnancy for pregnant women, we are not recommending doxycycline, even though we have now evidence showing that doxy could be safe, but we don't want to use it in pregnancy as of now. There we should be using azithromycin. As far as pediatric population is concerned, less than 2 years, we want to use azithromycin. 2 years and above, it is doxycycline. Means 5 to 7 days of doxy is safe in children above 2 years of age. And the next is means with regard to oseltamivir, the dose in the pediatric population. So dose actually, there are weight bands, and that is how we are going to give. The question was with regard to the capsule. How are you going to? I think the syrup is available now. The syrup is not available. I think we need to actually break it down and mix with honey, etc., and give it. But now the fluid syrup is available.
Yes. Then another question is, if doxy is started empirically and later the AFI looks more like ILI, should we stop doxy or change to oseltamivir, or continue doxy and oseltamivir along with it together?
In that scenario, it is like initially we are opting for doxy means that the patient is not having respiratory symptoms. So it is it is not an ILI sort of presentation. So if it had been an ILI sort of presentation at the first visit, so we would be starting oseltamivir. And here the question is, patient had an epidemiological link, etc., and then we had started doxy, and by say 48 hours, the patient is having severe sore throat and all, and then we are starting oseltamivir. There, there is no harm in giving it both, but the thing is, it's not easy to take both together. The oseltamivir will lead to gastritis, and doxy will also lead to gastritis. There, probably what we can do is you can do a total count, and if it is more like a viral picture, you can stop doxy and continue with oseltamivir like that. That decision has to be individualized. Some people will be able to tolerate both, but majority won't be able to tolerate.
And there is two sub-questions regarding oseltamivir. The one is how to manage that gastritis part of oseltamivir. There are sub-specific points there. One is the doctor has asked whether it could be sandwiched with the food. One, that is to prevent the gastritis maybe. And then second thing is, what is the best strategy? Because many a time, second or third day, patient becomes, it is troubling to continue and they discontinue. Certain.
Okay. The first part of the question is how to bring down the gastritis. So what we actually advise, we divide the patients in two categories. There are certain patients who don't have any problems with oseltamivir. There is another category, for example, me. I never had a problem with oseltamivir. But then the majority do have issues with gastritis and all. So there we actually give this pantoprazole or ioprazole, then ask the patient to take food after 30 minutes, and then ask them to take oseltamivir. So and then it's better to patient to be in upright position, just like doxy. For example, doxy we say that you take pantop, then food, and along with 1 glass of water you are supposed to take doxy, and you are supposed to be in an upright position for 30 minutes. We can apply that for oseltamivir as well. The second part of the question is, the patient may be able to take it for 2 to 3 days, and then because of persistent vomiting, patient is stopping it. But then you can have a reassessment, right? The patient is not having any red flag signs and all, you can stop it. There is no harm. The concept is that there is no compulsion to complete a course of anything. The longer a patient is on a particular drug, the more chance of resistance. Here, the most important thing is assess the patient for red flag signs. Suppose the patient is having features of pneumonia and patient is not able to take oseltamivir, that means that somehow we need to push it in. That means it is going to be hospitalization. You're going to start MSET, PANDOP, and then use oseltamivir. Suppose the patient is not having much of a problem. Now, say after 2 days, the only problem is gastritis, stop oseltamivir. That should be the approach there.
Then there is another sub-question which is arising out of that area, where, there are a lot of clinics and practitioners prescribing amoxicillin for 3 days and review after 3 days. And many occasions, patient gets some symptomatic relief and they don't report back. How mandatory is for completing course of amoxicillin in such cases?
Actually, in 1997 itself, there was a beautiful article in Lancet saying the antibiotic course has had its day. So there they have said that, we are using 7 days because, our Gregorian calendar something had 1 week had 7 days. Suppose 1 week had 10 days, you would be using it for 10 days. If 1 week, this 1 week was 5 days, you would be using it for 5 days. So the concept is that we require a prolonged duration of antibiotics only for osteomyelitis, it's bone and joint infections, endocarditis, and certain case of meningitis, like a gram-negative meningitis. For all other scenarios, now we say that shorter is better. Shorter is actually better. Means that, for example, there is a stop-it trial where for a ruptured appendix, they compared between 4 days of antibiotics versus 14. 4 was as good as 14. And the most interesting thing will be the guidelines for dental infections. Okay, dental infections guidelines, clearly says that American Dental Association, for a majority of the dental infections, the treatment is going to be the DCDT. That is a definite conservative dentist. That is the dental treatment. That is your root canal, etc. No role for antibiotics. Suppose you want to start antibiotics, it has to be either amoxicillin or augmentin only, no other antibiotics. And that duration is for 3 to 7 days. That's interesting. And for example, that is for pulpal necrosis, abscess, etc., they suggest antibiotics for 3 to 7 days. So on day 3, you have to reassess. Suppose the patient had been symptom-free for 24 hours. You can stop the antibiotic on day 3. Okay, so the duration is anywhere between day 3 and day 7. And telephonically, doctor is supposed to follow it up. Suppose the patient is becoming symptom-free on day 3, you can stop the antibiotic by day 4. So this is actually the dictum. So there is no hard and fast rule that, you need to give antibiotics for 5 days. Here my problem is with amoxicillin. Okay, a doctor should be using amoxicillin only if, diagnosis is a community-acquired pneumonia. For anything else, in Kerala, the treatment has to be doxy, because we are worried only about leptospirosis, strep typhus, because these are infections which can kill within a week. So we don't want to miss on strep typhus or leptospirosis, which can kill within a week. For a community-acquired pneumonia, you are going to have time. So no one is going to die on day 3 or 4. For a person with community-acquired pneumonia to die on day 3 or 4, that patient will be immunocompromised. A healthy person is not going to die due to community-acquired pneumonia on day 3 or 4. But a healthy person can die due to leptospirosis, can die due to dengue, can die due to strep typhus. That is why we always say that if you can rule out dengue, the drug of choice has to be doxy. And doxy is a wonderful drug. The only problem with doxy is it's cheap. So doxy is a wonderful drug. Those who can tolerate doxy has to be the drug if you want to start on this thing, in our practice. You can rule out viral infection.
If there is neutrophilia, like 80%, and the count is less than 11,000, is it an indication for antibiotic? And also if CRP is moderately increased, like 30 to 50.
Actually, the counts and the sepsis guidelines clearly say that the diagnosis of sepsis is never based on investigations. Okay, the diagnosis of sepsis is actually based on your history as well as the clinical examination. So you are thinking that the patient is having fever and thinking it's an infection. If there are features of say multi-organ dysfunction, like patient is saying the patient is having oliguria, patient is having tachypnea, tachycardia, so it's a multi-organ dysfunction, right? So that is sepsis. So the decision to start antibiotics is not based on the counts or the CRP alone, because during COVID, CRP was a severity predictor. So during COVID, one of the severity predictors was CRP. We always say that CRP elevated is back. It's not so. Because COVID, one of the severity predictors was an elevated CRP. Here, why I said that total count may be used is that, there is a discussion like, since, there are a lot of lepto deaths in the state, why can't you start doxy for all cases of acute febrile illness in the state? Okay. So there the problem is that the total number of acute febrile illness in the state is around 40 lakh. So for 40 lakh patients, if you are going to start doxy, doxy is going to become resistant. So if doxy is lost, means, it's going to be a huge issue. So out of this 40 lakh case of acute febrile illness, a big chunk is going to be in the respiratory infections. That is ILIs. Majority of the ILIs, no treatment is required because they belong to category A. For B1, B2, and C, you can start oseltamivir. So that you can bring it down to around 1 lakh cases of acute febrile illness, which are not ILI. There, it is going to be between, say, dengue, because dengue, the red flag signs we need to identify, versus strep. So even though we say that there are certain features like the eye shot, because the eye shot won't be there on day 1, right? Day 1 or 2, the lepto eye won't be there. So on day 1, 2, or 3, the patient will be presenting with fever, myalgia, headache. So it could be lepto or dengue. So that is going to be the problem, right? So both of them will be having the same presentation. Even if we are putting in diarrhea also, it will be there for influenza, dengue, lepto, etc. So fever, headache, myalgia, then it is lepto epidemiological links are there. So high risk occupation or say contact with water, etc. Don't take a chance. You start doxy. There is another group like you won't be having, for example, every day we are going to hospital and the scooter boom, is it an exposure or not? So that is going to be a problem, right? If you are taking it as an exposure, means that almost everyone will be having an epidemiological link. There, the total count can help you. So if you are in doubt, you do a TC. And if TC is less than 4,000, the chance of it being a lepto is less likely. It is more likely to be dengue, and or you can do a dengue NS1 like that. So the aim is to ensure that doxy is not given to all patients. So that is the only use for the total count, etc. Otherwise, between 4,000 and 12,000, etc., it is going to be the normal also, right? For example, scrub typhus, can present with leukocytosis, can have normal total count as well as sometimes it could be leukopenia as well. So our aim is to differentiate between lepto as well as dengue on day 1, 2, or 3. So.
And when we discuss dengue, there is another sub question: when one should do IgM and IgM, maybe NS1 antigen in dengue fever. Which one is more specific, IgM or IgG?
Actually, in the first week, it has to be NS1 ELISA. Usually, we do the CAR test also. That is also okay. So NS1 ELISA or CAR test in the first week, or dengue PCR in the first week, because the NS1, its sensitivity is not 100%. So if you are really suspecting dengue, especially in dengue encephalitis and all, and if NS1 is coming as negative, we actually use PCR as well. IgM ELISA usually starts becoming positive from day 6 onwards. That is, in the second week, you should be using IgM ELISA. Regarding dengue IgG, that is actually you can do during the first week also. It's not as a test for the current infection. It is to see whether you had dengue in the past, because usually we say that secondary dengue can lead to severe dengue. So just to know that, if you want, you can do dengue IgG. That can be done in the first week. That's
and I got remembering, like, a mnemonic IgG means G means prospects for previous, a bit more older one. Okay, then there is another question: do all ILA, influenza like illness require oseltamivir? And can you share specific information about absolute indication for the use of oseltamivir? And there is another sub question on that. In the era of antimicrobial resistance, will we be facing an oseltamivir resistance?
Actually, the second part is going to be the most important one. Like if you are using oseltamivir for everyone, will oseltamivir resistance come in? Actually, prior to the 2009 pandemic H1N1 strain, we did have oseltamivir resistance. So when the circulating strain was replaced by the pandemic strain, actually oseltamivir resistance has come down a lot. And ICMR monitors this resistance. And as of now, according to ICMR, we don't have a major problem with oseltamivir resistance. That does not mean that we should be using it right and left. Now, I think the only deterrent to using it right and left is the cost of oseltamivir. So we need to be choosy about on whom we should be starting oseltamivir. So we say that you have to classify into this ILA. ILA also category A, B1, B2, and C. Category A, there is no need for antivirus. That does not mean that the patient does not require a treatment. Symptomatic treatment should be given, that is paracetamol, cetirizine, etc. And then we should educate them about the red flag signs. And if they develop red flag signs, they have to come back. Or if there is a progression from A to B1, then also we need to start oseltamivir. B1, definitely we need to start oseltamivir. That is high-grade fever and severe sore throat. B2 is going to be the problem. So B2 is those with comorbidities. So those with comorbidities in Kerala means 30% of the population, right? So 30% with diabetes, 30% hypertension. So that is where we need to be a bit choosy. Pregnancy, definitely give oseltamivir, because we have burned our fingers pregnancy influenza in 2016-17. So one good thing about the K4G, their organization, so they educated all the pregnant ladies, and not the pregnant ladies, all the obstetricians, that any patient with respiratory symptoms, you need to start them on oseltamivir, and that has bring down the mortality due to influenza a lot in our state. So pregnancy, definitely any ILI, you need to start oseltamivir. Regarding should you start oseltamivir for all patients with diabetes, I will say that no. If it is uncontrolled diabetes, you need to start. Likewise, you can have a stratification regarding which sort of comorbidities it has to be started. Elderly, definitely you need to start. And the pediatric population, neonatology, etc., you need to start. Pediatrics means, the young children you need to start, not for the healthy children and all. Then regarding CLD patients, definitely you need to start. CKD on dialysis, you need to start like that. Okay, so basically you need to pick and choose for which commodity we need to start. And don't forget about the vaccination also. For example, for all this category of people, the influenza annual vaccine is definitely going to bring down the severity of the infection.
That vaccination, how can we time the vaccine after an ILI? Is there time gap? Is there any time gap required after the illness?
Actually, after any ILI due to a virus, I will suggest that vaccine is not immediately required. The reason is that whatever be the virus leading to the infection, there will be an interferon response. Okay, so if there is an interferon response, that interferons are going to protect us against any virus for the next, say, 1 to 2 months. So suppose we are hell bent on taking a vaccine, we need to ensure that we are fully recovered. So that will be around 2 to 3 weeks, so that our body can mount a very good immune response. That's all.
Now there is probably the most commonly common confusion. Like, many time patient presenting with fever, sore throat, people are, prompted to start azithromycin. Okay, and this azithromycin, you have any direction on that? And then the use of erythromycin for fever, particularly dengue or leptospiree.
The thing regarding the azithromycin, it is now referred to as the new vitamin A. Like it's being used right and left, so that azithromycin is virtually useless because we are giving azithromycin for pneumococcus, right? So if you're looking at the pneumococcal resistance to macrolides in India, in 2002 there was a study showing that the resistance was 4%. In 2020, it had become more than 50%. Okay, and after COVID, it is actually, because Azithral is a brand during COVID-19 time, this 2022 Delta wave. The sales of Azithral in India was more than 1,000 crore. It actually surpassed this human mixture, the sales of human mixture. And we knew that it was a viral infection, right? So it's not like ILI. So during COVID time, we knew it was COVID-19 because we are using molecular tests like anything. Despite knowing it is a viral infection, we use azithromycin. So the problem here is that if you are using azithromycin on day 1 for an ILI, the chance of it being viral is actually more than 90%. If you are using azithromycin on day 1, what happens is that the whatever the microbes are there in your nasopharynx is going to become resistant to the macrolides. Okay, so it is going to be a macrolide resistant pneumococci, etc. And usually the secondary infection is going to occur. In a viral infection, it is going to occur by day 7. That is, you initially have fever, sore throat, etc. And then it comes down, and by day 7, you are having a recurrence of fever again with, say, purulent sputum and all. That is when antibiotics are really indicated. So unfortunately, you had given azithromycin on day 1. On day 7, you are supposed to give something else. It will be augmentin sort of thing. But the problem here is that pneumococcus is becoming resistant to such an extent that azithromycin is actually veritably a useless sort of thing. Usually, my telephonic consult will be like that. Even doctors, they will call me up and say that I have this fever and sore throat. ഞാൻ azithromycin കഴിച്ചു. It's just like taking a candy, he's saying. Okay, azithromycin കഴിച്ചു എന്നിട്ട് കുറഞ്ഞില്ല. 5 ദിവസമായപ്പോൾ ഞാൻ Tamiflu, Versatamur കഴിച്ചു. ഇപ്പോൾ 8 ദിവസമായപ്പം പിന്നെയും മീൻസ് കഫമൊക്കെ നല്ല മഞ്ഞയായിട്ട് വരും. ഇവിടുത്തെ സീക്വൻസ് ആണ് തെറ്റിപ്പോയത്. ഇവിടുത്തെ സീക്വൻസ് എന്ന് പറഞ്ഞാൽ ആക്ച്വലി day 1, day 2 ക്ലാസിഫൈ ചെയ്ത് you should have classified ILI into suppose you had been category B1, you should have started Oseltamivir then. Oseltamivir is going to give some symptomatic relief in category B1, B2, etc. started within 48 hours. There, what was started? It was azithromycin. So you missed the opportunity to start Oseltamivir, which would have given you symptomatic relief. And instead, you started Oseltamivir on day 5, where it is actually useless. But means totally unscientific കാര്യം ചെയ്തു. That is, instead of starting Oseltamivir within 48 hours, you started Oseltamivir on the 5th day, where it's not going to help you except in critically ill people. Then azithromycin on day 1, no use. The only use is that the microbes in the nasopharyngeal flora would have become resistant. And on day 7, you'll end up using some other antibiotic. So this sequence should never happen. So it has to be oseltamivir, and antibiotics are indicated only if there is evidence of secondary bacterial infection. So antibiotics can never prevent a secondary bacterial infection. The only thing antibiotic can do is it can ensure that you will get infection with a resistant microbe. Okay, that is the only thing antibiotic on day one will ensure. So I start with antiviral if it is indicated, and if there is evidence of a secondary bacterial infection by day 7, then you start an antibiotic, which could be your amoxicillin or augmentin, or if you want azithromycin, like that. Okay, but mind you, for all the severe infections with pneumococcus, your azithromycin is not going to work. So that is why, we are using ceftriaxone and azithromycin. There, azithromycin is used as an immunomodulator, not as an anti-pneumococcal drug.
Yes. Since we
are
are
problem, so I'll add one more line, sir.
Please.
So what happened is that in 2024 we had a huge mycoplasma outbreak in the state. So huge mycoplasma outbreak, and mycoplasma was not responding to azithromycin. So we had misused azithromycin to such an extent that the mycoplasma was not responding to azithromycin. There is a study, because mycoplasma we can't culture. So there is a study based on genomics from Amrita, which demonstrated that around 40% of the mycoplasma in our state was resistant to azithromycin, whereas the data from China says 95% resistance to azithromycin among mycoplasma, but data from USA says that the resistance is only 3%. So if we safeguard our antibiotics, we can be like USA. Otherwise, we are about China icon. There also we ended up using doxycycline, okay, because doxy surprisingly, still maintains efficacy against mycoplasma. Shigella, when you are looking at the antibiogram, the problem is that resistance is so high. So all these things are occurring because we are misusing antibiotics. പിന്നെ എന്തിനാ എല്ലാത്തിനും ഡോക്സി എടുക്കാൻ പറയുന്നത് ചോദിച്ചു കഴിഞ്ഞാൽ, അല്ലാതെ വേറെ മാർഗ്ഗമില്ല ഈ ലെപ്റ്റോസ്പൈറോസിന്റെ ഡെത്ത് ടു ആൻ എക്സ്റ്റെന്റ് കുറയ്ക്കാൻ വേണ്ടി. അതുകൊണ്ട് മാത്രമല്ല ഡോക്സി ഈസ് എ access category antibiotic, whereas azithromycin is a wash category antibiotic. So if you feel like using an antibiotic, then always select antibiotics from the access category.
Absolutely. Though we have, we are very short of time. Let me ask one more two questions too. Like, every time doing complete blood count and blood routine, I don't know, actually, is there any comment on that?
Actually, all these tests are very good in the right hands. Okay. So for example, like you're having a leukopenia and you're having, say, a thrombocytopenia, and if you can make, and if there is a hemoconcentration, you can say that it is a dengue, and if the hemoconcentration is occurring, means the patient is developing capillary leakage. So just blindly doing these hemograms are not going to be of any help. You have to interpret all these aspects in a very, very good fashion. For example, a patient is having fever of 7 days duration, and there is a leukopenia, and there is eosinopenia also, and there is a history of recent travel to, say, Madras or something like that. Eosinopenia can point to us enteric fever, eosinopenia plus leukopenia, like that. All these tests are very, very important if it is in the right hands. Another example is a patient is coming to you with membranous tonsillitis. So membranous tonsillitis, we always think that we need to rule out diphtheria. Suppose you are doing the LFT and if there is a transaminitis, usually transaminitis won't be there in diphtheria. So it is an IMN sort of thing. So lymphocytosis, transaminitis, membranous tonsillitis is IMN. So all these investigations are important if we know to interpret in the right way.
Absolutely. And then one more thing, like, one more thing is, like, let us comment on in vaccination and just close because it is high time. He is also from the hospital, and now influenza vaccine schedule in elderly. Can you also comment on the the vaccination? There are two issues. The yearly influenza vaccination. Is it mandatory? And if so, geriatric group and even the medical group, like, the doctors, how mandatory is it?
Actually, elderly population, definitely we should go for vaccination. There's pneumococcal vaccination as well as the annual influenza. So annual influenza is going to be the most effective for them. Unfortunately, in India, we don't have the augmented these vaccines. For example, in elderly, there is something known as immunosenescence, and they may not be able to mount the same antibody response as the young. So in the US, instead of 15 microgram, that is, they are using 60 micrograms. That's a 4 times the dose is there in the influenza vaccine. We don't have that vaccine in India, but something is better than nothing. So annual influenza vaccination at the right time, it's just prior to April in India, is important. And for the healthcare workers, that is the most resistant group. I will say that there are two why you should be taking the vaccine. One is to safeguard your health, and second is to safeguard the health of the people you are treating. And you can actually categorize the healthcare workers into people who frequently become ill. But then നമുക്കറിയാം ചില ആൾക്കാർക്ക് എന്ത് വന്നു കഴിഞ്ഞാലും അധികം സിംറ്റം ഒന്നും വരത്തില്ല. It may not be easy to force them to take the vaccine. That group definitely always should wear a mask because they should not be spreading it to others. There are other doctors who frequently become ill due to influenza or COVID. These are the people who are going to have maximum benefit out of vaccination. So whatever said and done, whether you are vaccinated or not, in the hospital, you should always ensure that you are wearing the mask for your safety as well as for the safety of your patients. The second aspect is that you should never compromise on the 5 moments of hand hygiene. So these two things we should safeguard, always practice in the hospital for our health as well as the health of our the patients for whom we care. Because you know that especially in immunocompromised patients and all, they may be dying of influenza which is given to them by us. So always we need to ensure that we practice this. And definitely the influenza vaccination, all the agencies, WHO, CDC, etc., and APA and all mandates the use of influenza vaccine annually in healthcare workers.
Pneumococcal vaccine?
Pneumococcal vaccine not for healthcare workers, but for elderly, as well as those who are having post-planectomy and the T cell deficiency, quantitative or qualitative T cell deficiency, like those who are on immunosuppressants, etc., they should take the vaccine. And now we have the Prevenar 20. Since Prevenar 20 is available, only 1 dose is enough.
And we have to use erythromycin instead of doxy in pregnant ladies and in below 2-year children, which is already commended, right?
Yeah.
So actually, we didn't never use
azithromycin.
We were recommending erythromycin. And then anything, I think we did not miss any important questions. And now there is one last word. Even though we think we know everything, there are a lot of things we need to either relearn or unlearn something and relearn again, right? And please, let us sign off with the moments of hand hygiene. Let us just have a word about hand hygiene. And because, many a time, hand hygiene, just applying sanitizer and then moving on. And please share your comments.
Actually, one of the most important things that we can do to safeguard our health as well as the health of our patients is to ensure hand hygiene. For that, the 6 steps are important as well as the 5 moments are important. These 5 moments are actually before touching the patient, after touching the patient, before doing a procedure, after doing a procedure, and after touching the patient's environment, which includes the case sheet also. So these are the 5 moments of hand hygiene. And if you're actually practicing the 5 moments of hand hygiene, so we can prevent ourselves from getting colonized, and through our hands, we can prevent the transmission of pathogens too. That is, we can prevent cross-infection. So this is very, very important. So this is the single most step or the preventive strategy which can bring down the healthcare, the gamut of healthcare associated infections in the hospital by multifold.
Sanitizing hands, how many seconds it takes effect?
Actually, if you're going for hands, this alcohol-based hand rub, 20 to 30 seconds is actually enough. So, and whenever you get an opportunity to do the hand washing, you can do that as well. There are certain situations where, this hand washing with soap and water is superior to hand hygiene. That is, if you're having an outbreak of a Clostridium difficile, because the spores are not destroyed by our alcohol-based hand rub, and also by norovirus. Previously, we used to think that we don't have norovirus. Now we have this molecular facility. A lot of diarrhea outbreaks in our state is due to norovirus infection. So in such situations, this hand washing is superior to hand hygiene. Another important aspect is most of the problematic viruses are enveloped viruses. For example, our Nipah, our Ebola, etc. These are enveloped viruses. Enveloped viruses means that this can be killed easily by soap. So just by adopting this, moments of hand hygiene, even Ebola and Nipah can be kept at bay.
Absolutely. I'm so sorry to keep you holding on this, prolonged doubt clearing session. It was actually an amazing session and eye-opening one. I don't want to prolong any further. Dear Dr. Aravind, being an icon, being a, what I should say, not only a whistleblower, you are a true torch bearer in this gray, in an area where as I initially told, there are people who go through charted sea, and you went to uncharted sea and showed us a big amount of light in an area of darkness. So the modern medical profession, Indian Medical Association, and all of us remain greatly indebted. And we please do convey our regards to you, your family too, because it matters, because we know. Thank you very much, dear Dr. Aravind. Please do stay focused in this arena, and we are all there with you in every moment. Thank you very much. And friends, this is a moment of sharing our happiness with Dr. Aravind. We need to support people like particularly he's working in a government setup where it is not at all easy to go and do things. And he's there whenever there is a call from the government, whenever there is a call from the fraternity, and when there is a call from the ward, he's there. And we are extremely proud of you. Thank you very much, Dr. Gad.
Thank you, sir. Thank you.
Thank you. Friends, it's time for us to leave, and let us meet in the next Thursday, 8 p.m. with another eye-opening session on bronchial asthma by the professor and head of the pulmonology department, Dr. Shah Jahan, a man, a doctor, and a true human being, and a great social worker. We'll have an amazing session on bronchial asthma next week, Thursday, 8 p.m. So, friends, wish you all a good night. Good sleep is essential for health. Have good sleep. Let us switch off the visual, all this thing, and go for a good sleep. Thank you all.
Thank you, sir.
Thank you.